Good morning. Thank you for the wonderful introduction. So my job is why we need to describe or define why we need this Global Nephrology Summit. Two organizations steeped in history came together to take the nephrology to the summit in this event. The AAKP was started in 1969 by 6 dialysis patients in Kings County, Brooklyn. Now it has grown out to be a nationally recognized patient organization that reaches over to 1 million people annually. It is committed to improving the quality of life for kidney patients through education, advocacy, and patient engagement. GW School of Medicine was founded in 1824 as a Columbian College, Department of Medicine, which is now called the George Washington University. It is the first in the nation's capital and 11th in the nation as a medical school. The first life-saving hemodialysis was performed in GW Hospital in 1956, just barely 2 years after it was introduced into the US, in fact, in the world. In 1964, it opened Washington's first non-military dialysis unit that is open to the public under Dr. Alvin Parrish. The rich tradition of continued renal care at GW continues even today. Everybody agrees that there is a global CKD epidemic. There are about 850 million people with chronic kidney disease in the world. It causes about 2.4 million deaths per year. It's the 6th fastest growing cause of death. Everybody wants kidney health for everyone and everywhere. In spite of our effort, the global burden of chronic kidney disease is exploding, as you can see during the last 3 decades. The prevalence of CKD has increased by 87%. The death and disability due to CKD has increased almost by 100%. The burden of CKD is larger in developing countries, which does not have adequate health infrastructure. The number of clinical trials performed in nephrology is the lowest, but it is the highest in cardiovascular disease. It's unfortunate that the Medicare spends about $30.9 billion for treating ESRD patients in 2013, which is more than the entire 2015 NIH budget of $30 billion. If we had spent more money on innovation and research, this would have prevented the cost directed towards healthcare. NIH spends, and the ASN Research Advocacy Committee estimated that NIH spends about $2,500 per individual with HIV infection and $500 per patient with cancer, but it spends only about $30 per CKD patient. Thereby, the innovation in CKD has been but languid. Chronic kidney disease is a key and important cause of cardiovascular disease. Yet, after 371 cardiovascular disease intervention trials conducted between 2014 and 2015, 57% of them excluded patients with kidney disease. The editor of JCI and Kidney International, Akwati, he lamented that the number of basic science research in kidney disease is declining. This shows the number of FDA-approved drugs from 1990 to 2017. You don't even see nephrology mentioned anywhere there. There are about 200 drugs in the pipeline in 2010, of which there were minimal representation for kidney nephrocentric drugs. We all love kidney. To quote Homer Smith, the composition of blood is determined not by what the mouth ingests, but what the kidney keeps. They are the master chemists of our internal environment. He further stated, bones can break, muscles can atrophy, even the brain can go to sleep without endangering survival. But when the kidney fails, neither bone, muscle, nor brain can carry on. This is the research done by Tonelli et al. From Canada. They looked at the electronic medical record system and they said the patients seen by nephrologists have the highest number of comorbidities, highest number of prescribed medications, and highest rate of death. In other words, they manage the most complex patients. A survey conducted by the American Society of by the George Washington University on behalf of the American Society of Nephrology concluded that nephrologists are very unhappy in their profession because of long work hours and undercompensation. You ask the residents, they say, we love nephrology, we admire nephrologists, but I don't want to be one. Since the inception of Bright's disease in 1827, nephrology has grown by leaps and bounds, led by stalwarts like Homer Smith. Introduction of hemodialysis in the 1960s prevented certain death due to ESRD. The first organ to be transplanted is kidney in 1954. Kidney, liver, pancreas, and other transplants didn't follow till 1960s. We led the innovation in immunology of transplantation. And what happened to their innovative resilience in nephrologists? We're still wondering. But the dawn is not distant, nor is the night starless. The Kidney Health Initiative was formed in 2012 to foster development of therapies by creating a collaborative environment in which FDA and nephrology community could interact. The Congressional Kidney Caucus acknowledged the epidemic of CKD and need for increased investment and resource coordination to address this epidemic. NIH, one of the complementary initiatives by NIH is the KPMP, which is the first step towards precision medicine to create a kidney tissue atlas, define disease subgroups, and identify critical cell pathways and targets for novel therapies. ApoL1 is associated with the increased risk of CKD and progression to ESRD. The Apollo study is designed to identify the risk for chronic kidney disease in donors as well as the recipients, again funded by NIH. The Kidney X is conceived as a partnership between US Department of Health and Human Services and the American Society of Nephrology to accelerate innovation in the prevention, diagnosis, and treatment of kidney disease. So what we aim to accomplish in this conference? To put policy insights and perspectives from diverse sectors of kidney health in the context of cutting-edge science and innovative practice solutions, to identify challenges, discuss solutions, and define the research needed to inform and evaluate policies in order to improve kidney health, to discuss inequalities in care delivery, explore opportunities to improve kidney health through global strategies, alliances, and policies. To summarize, there is a large global burden of CKD with poor outcome. Decreased resource allotted to kidney research has led to positive innovation in nephrology. Lower compensation and higher workload has resulted in reduced nephrology workforce. Partnership among patients, policymakers, providers, inventors, and investors is crucial for innovative discoveries and delivering them to our patients. Thank you.